So after understanding the initial clinical evaluation and imaging of the patients presenting to us with low back pain, we should be able to understand in details about the degenerative disc disorder, which is the most common cause of low back pain, especially in adults. So to understand that, let's start with the normal anatomy of the disc that makes almost 15 to 20% of the length of the spine and provides flexibility to the spine. The disc has nucleus pulposus, which is a gel-like material in the center, and surrounded by annulus fibrosus, which is arranged in 3 different layers around the nucleus pulposus, and is arranged in the form of crisscross arrangement, because of which it is very strong and does not let the gel-like nucleus pulposus to come out while providing flexibility to the spine. There is also cartilagenous end plate on both the sides of the nucleus pulposus of the disc. The degenerative process is marked by altered matrix components, change in the cellular number, and change in cell phenotype and metabolic activities in both these nucleus pulposus and annulus fibrosus components. The resulting reduced disc height, disc bulging, and loss of annulus fibrosus to nucleus, and the nucleus pulposus to annulus fibrosus demarcation is seen with degeneration. So Willis has given a cascade which shows the natural history of progression of degenerative disorder from dysfunction to instability to stabilization. And the dysfunction occurs at a young age, in which case most of the patients might present with history of prolapsed intervertebral disc. Slowly it passes to a phase of instability as the annulus fibers get more lax because of the nucleus getting dehydrated, and there is instability and movement between the vertebral bodies causing a lot of back pain. This instability slowly produces hypertrophy of the facet joint, hypertrophy of the ligamentum flavum, and which leads to the stabilization of the stabilization phase of the disc, and the movement is lost. Whereas because of the hypertrophied flavum, the hypertrophied facet joint, and the buckling annulus fibrosus, there is compression of the nerve roots at the level of this disc, causing stenosis. So the patients, especially the elderly patients, present with a lot of stenosis. In instability phase, patients mostly present with spondylolisthesis. This is shown in this cascade. The conservative treatment of back pain has been shown to be very effective in most cases. That starts with physical therapy and exercises. It's a continuous process with a focus on developing immediate, intermediate, and long-term goals determined at the initial evaluation of the patient, that is determined by the pain level and functional limitation of the patient. Rest for a few days and using braces for a few days is helpful, especially in acute low back pain. Likewise, weight reduction and modification of the job is very helpful in the long run. Initial physiotherapy given is to decrease the pain level with a series of modalities like heat therapy, cold therapy like ice, or transcutaneous electrical nerve stimulation or massage. The next session will be a back school program in which we educate the patient on the anatomy of the spine, common cause of back pain, the posture of the body, and the stability, and may include instruction on gait and balance of the body. Heat therapy could be again superficial, like with heating pad, warm compresses, or fluid therapy that gives muscle relaxation and analgesia, whereas deep heat is provided by ultrasound stimulation, ultrasonic therapy, or shortwave diathermy or microwave. The cold therapy, which is shown to be more effective, especially in acute cases, can also be given with ice, The lumbar stabilization exercises, especially the core strengthening and the back strengthening exercises, along with the stretching of these muscles, can be done in these patients in the long run. The exercises most commonly done and are very useful are the plank, which helps to strengthen the core, and the different Pilates exercises, which help to strengthen both the core and the back muscles. The aerobic exercises, yoga, tai chi, that is done in Chinese, that is common in China, is also found to be quite helpful in these patients with back pain. Likewise, we have to educate the patient on proper ergonomics. Mckenzie Exercise program, which is a mechanical diagnosis and therapy program, is also found to be quite effective. Is proposed by Robert Mckenzie, who says answer to most problems of the back are within the patients themselves. It is a philosophy of active patient involvement and education for back, neck, and extremity issues. There is philosophy of centralization of the pain from the periphery with a series of movements and again peripheralization. So this Mckenzie exercise is found to be quite effective in most patients presenting with back pain to our outpatient department. The pharmacotherapy, and the safest of medicine is the acetaminophen or the paracetamol, which is also the first line option, followed by non-steroidal anti-inflammatory drugs, which inhibit the cyclooxygenase enzyme. And they are also the first line drugs, but have been associated with a lot of GI and renal side effects. The COX-2 inhibitors, selective COX-2 inhibitors, which are commonly used these days, have been associated with a twofold increase in myocardial risk. So although they are very effective, so the patients with cardiac risk factors should not be given these COX-2 inhibitors like etocoxib. Naproxen has the lowest cardiac risk because these cases are mostly elderly. We have to be cautious about the myocardial risk. The muscle relaxants are better in acute back pain for the relief of muscle spasm in the back. And the muscles like chlorzoxazone, tizanidine, for example, are quite effective muscle relaxants for cases with low back pain. The other medicines that are commonly used are antidepressants. The tricyclic antidepressants like nortriptyline or selective serotonin norepinephrine reuptake inhibitors like duloxetine, or even SSRIs for that matter, selective serotonin reuptake inhibitors can also be used. The synthetic opioids like tramadol or other opioids like hydrocodone or oxycodone can be used in combination with paracetamol, but have been associated with side effects of constipation, nausea, somnolence. So patient may not tolerate in all cases. The steroids are quite helpful in acute setting, especially patients with prolapsed intervertebral disc, in which giving a steroid either by injection to the level of the inflamed nerve root or giving oral steroid is helpful in reducing the inflammation of the compressed nerve root and hence reducing the pain. The anti-epileptic medications like gabapentin or pregabalin are very helpful in chronic pain with radiculopathy. The analgesics and ointments like capsaicin, lidocaine patch, or diclofenac ointment can also be given. Some other alternatives like herbal medicines or acupuncture are also commonly used to treat cases with low back pain. There is clear evidence that non-operative treatment has a role in most patients with low back pain, that they improve without surgery by 6 weeks, is shown by a very popular trial, that is sports trial. The surgical management mostly these days involves minimally invasive surgery for the prolapsed intervertebral disc or degenerative spine, where we decompress through a small keyhole approach and decompress the nerve root and reduce the pain in these patients. While planning surgical management, we have to take special consideration to the sagittal alignment of the spine, because every degenerative case in which the disc is flattened and the lumbar lordosis is lost, we have to treat these cases as deformity case as well. So there is a constant battle between the loss of lordosis and compensatory efforts, and if this is not taken care of, then the surgery may not be very helpful and the patient will still complain of pain and disability. So different measurement parameters for the sagittal alignment are the plumb line, SBA, pelvic tilt or pelvic incidence, and so on. And there is a correlation of the oswestry disability index and this SBA, that is sagittal vertical axis, which shows how much anteriorly displaced is the vertical line dropped from C7 with respect to the sacrum. So there is correlation of this sagittal alignment and the adjacent segment disease as well. So if we do not correct the sagittal alignment, the patient will again come for second surgery because of the adjacent segment issues. So these are the different angles we draw. This is to show the sagittal vertical axis. So this is normal, that passes through the posterior superior corner of sacrum. This line passes quite anteriorly. So SBA is quite anterior. It means because of the degeneration process in the lumbar spine, the patient is stooping forward, and to maintain the upright posture, patient has to do a lot of compensatory efforts with flexion of the hip, knee, and straightening of the back. So all of this gives the patient a lot of disability. So for the first case, the case of scoliosis, we did scoliosis surgery, scoliosis correction surgery, and the patient improved. For the second case with prolapsed intervertebral disc, a small keyhole operation was done, making a small incision to pass a small tubular retractor, and the disc was removed, decompressing the knob root, and the pain, and the patient was relieved of low back pain as well as the leg pain. Whereas for the patients with the infective pathology, there was problem with the bone defect anteriorly because of the infective pathology, as well as problem with stability and some compression of the knob roots. So in this case, we did remove we did the debridement, thorough debridement of the disease, and we stabilized with posterior instrumentation, a long posterior instrumentation, to give stability to the spine. So spine infections are some of the other important causes, especially in our setting in developing countries, which are often missed in the outpatient clinic in the first few visits. So we have to know in detail about these spine infections, but I will I'll just go in brief. So 3 to 16% of all bone and joint infections occur in the spine. The pyogenic spondylitis accounts for 95% of vertebral body involved. The predisposing factor of spine infections are diabetes mellitus, malnutrition, HIV, malignancy, long-term steroid use, chronic renal failure, cirrhosis, or septicemia. There is bimodal age distribution, young patients and patients in the 5th or 6th decade of life. Again, the organism, Staph aureus and Streptococci are form the majority of infective organisms. Gram-negative organisms are common in cases with intravenous drug abuse, or in cases with renal failure, and anaerobic organisms can also be seen in some cases. The mode of spread to the vertebrae is mostly arterial route, and these patients mostly present with insidious onset back pain, with severe pain with gross destruction of the vertebral body and involvement of the posterior elements as well. Sometimes involvement of the facets is seen. There is a radiation of pain suggesting compression of knob root by the abscess of the granulation tissue. So again, the red flags are to be seen. The investigations that we have to do for these ruling out these infections are the total count, differential count, ESR, CRP, and some other important blood tests, including blood culture and urine culture. The biopsy is very important in some cases. Like these days we have facility of doing CT guided or image intensifier guided percutaneous biopsy. It gives us the sample so that we can culture the sample and identify the organism. At the same time, we can also rule out any other causes like metastasis. The radiological studies like X-ray, CT, MRI, and radionuclide scanning are helpful in these cases. So this is the CT scan showing gross destruction of the vertebra. The treatment is again conservative or surgical, depending on what the pathology is, whether it is a pyogenic or tubercular. We can treat conservative or surgical, depending on the need of the patient, whether the nerve root is involved, or if there is instability of the vertebra. So again, this is the MRI showing the hyperintense signal intensity at the level of L5S1, showing spondylodiscitis. So sacroiliac joint pathology is also a very important cause of low back pain, significant source of disability that often causes buttock pain and leg pain as well. The dysfunction could be because of inflammation, is also seen in pregnancy, could be after a lumbar fusion, or could be after a traumatic event, traumatic injury to the SI joint, or sometimes even a degeneration of the SI joint has been associated with pain and instability of the SI joint, dysfunction of the SI joint. The diagnosis, again, is based on thorough clinical evaluation. There is a 14-finger test. The patient will point the finger to the posterior superior iliac spine, showing the region of pain. So this indicates there is involvement of the pain could be from the sacroiliac joint. So there are a series of tests done, 6 diagnostic examinations done in supine, lateral, and prone position. If 3 or more positive tests, then it could be a case of sacroiliac joint pathology. The most important test is a Ganselin test that is done in lateral position, is in this case, in which we extend the involved part of the hip while flexing the contralateral part and seeing for any reproduction of the pain with this maneuver. So the treatment of sacroiliac joint pathology could be non-operative with physical therapy, core or pelvic stabilization exercises, or non-steroidal anti-inflammatory drugs. Sometimes injections could be helpful, both in diagnosis as well as treatment. Radiofrequency ablation has also been shown to be effective in the treatment of sacroiliac joint pathologies. Whereas surgery with minimal invasive sacroiliac joint fusion or open fusion are the options. So after putting a patient of low back pain in treatment, whether it could be operative or non-operative treatment, we have to evaluate the outcome with various functional outcome scores, and the most important of which is the OSWAST Disability Index that we discussed earlier, and some pain scores. We have to see the different pain scores, the most important of which are the VAS analog, visual analog scale, or numeric pain rating scale, which are commonly used. So this is the visual analog scale, from the happy face to a very sad face in agony. We can ask the patient to point out which severity, which intensity their pain could be. So the patient will point to a certain severity of intensity of pain by themselves. So the prognostic factors after any treatment, operative or non-operative, depends also on the smoking, education of the patient, geographical variation, psychological factors, occupation of the patient, and workers' compensation is also associated with variation in the outcome of treatment in these patients. Even after conservative treatment and followed by surgery whenever it fails, a lot of patients still come to us with chronic back pain, which are grouped as a case of failed back surgery syndrome, which depicts a patient who has either not benefited from a spinal procedure or who has had complications that led to a less favorable outcome. So this is quite troublesome. The evaluation is complex and difficult. A thorough workup, including the image to localize the structural pathology, is warranted. So the further surgery aimed at the specific pathology can be planned. In absence of the definitive pathology, non-operative care should be recommended, and spine surgeons should collaborate with colleagues specializing in non-operative care of these patients for optimal treatment, like the physiotherapist or pain medicine specialist. Thank you very much.